Hi, everyone. First of all, I would like to thank for the invitation. I'm very happy to be here to present you the R-Link initiative as an illustration of the objective we have for the development of precision psychiatry. So R-Link is an international collaboration that started 6 years ago, 7 years ago, and that involved many countries across Europe, plus some SMEs. And the aim of my presentation is to describe the ambition and the objectives of this international initiative. So I will start with the context and the rationale for this study. The organization, I will say a few words about the organization and the structure of the project. So this project aims at the identification of predictive biomarkers for lithium response. So I will spend some time describing all the biomarkers we're collecting in this study. And I will also describe at the end, because we just finished the collection of the data, I won't be able to present any results because the analyses are ongoing, but I will share with you the available data after 6 years of work, and I will finish with an illustration of what would be molecular signature to predict lithium response. So the overall aim of this project was to identify eligible criteria for long-term treatment with lithium in bipolar disorder. And our definition of response was both therapeutic response, but also safety and tolerability aspects. And the ambition is to identify these criteria through the validation of biomarkers transferable to bedside in order to improve the prediction of response and to promote early stabilization in bipolar disorder. So just the first aspect of the context of this study is that, just to remind you that lithium is the first-line treatment in most guidelines. The efficacy has been demonstrated for the treatment of acute mania, acute depression, as well as relapse prevention. But we have tons of literature showing that we have an important variability in response. We have about 30% of patients with a fantastic response with the perfect control of relapse risk into depression or mania. And at the other end of the spectrum, we have about 3 to 40% of non-responder despite adherence to treatment. And in between, we have a group of patients with a partial response of lithium. So in this context, we have two major challenges. The first one is that despite many studies that investigated the existence of predictive indicators for lithium response, the results of all these studies show that we are unable to predict who is going to respond to lithium. That's an important objective to better predict long-term lithium response, to avoid empirical approaches, because and to promote early stabilization. And the other challenge is that we still don't know how lithium is acting. Lithium is like we used to say, a dirty drug. With activation and inhibition of many biological pathways, and inside this biological storm, we're unable to identify which biological pathways are associated with response or side effects. So many works remain to be done to elucidate lithium mechanism of actions. So the rationale for the Arling study was the starting point was no predictive biomarkers, and we are lacking prospective studies. So we are, when prescribing lithium, we are we are facing unpredictable outcome and tolerance, and the clinicians rely on empirical approaches. It has also been mentioned in previous presentation, lithium exposure is poorly controlled in regular clinical practice, and the overall adherence to lithium remain poor. So the ambition for the Arling project was to identify predictive biomarkers of long-term response. We would like to contribute to the development of predictive and personalized approaches, optimizing the monitoring of lithium exposure, and also to promote adherence to treatment in general. So the design of the study is very simple. We collect... sorry. Probably this one. Yes. So we collect biomarkers before and after lithium initiation. During the first 3 months of the trial, we include patients whose clinicians has indicated lithium as maintenance treatment. And so we include participants eligible for lithium initiation based on their clinicians' indication. So blood and MRI biomarkers are assessed before and 3 months after lithium initiation, and then the response was evaluated during a 24 months prospective evaluation. Biomarkers that are collected during this initial phase are, of course, we collect illness characteristic, patient's characteristic, some cognition aspects. There was an optional module for some patients who accept to participate to a 3 months actimetry collection. In terms of biology, we of course go on contributing to the Lithium Pharmacogenetic Consortium, but also collected blood samples to run mRNA, microRNA, epigenetic marks, and proteomic profile before and after lithium initiation. In terms of neuroimaging, there was a work package dedicated to anatomical and DTI neuroimaging biomarkers to be tested with response. And as David Cousin just presented you, we have a work package dedicated to the collection of brain lithium data 3 months after lithium initiation. At the beginning, we had 3 sites, and at the end of the project, we end up with 6 or 7 sites, right? So that's the structure of the project. We have the work packages are dedicated, are separated, are stratified by expertise. The work package 3 is led by Alan Young for the clinical study. We have a work package dedicated to the classical MRI acquisition led by Paolo Brambilla. A work package dedicated to lithium imaging led by David Cousin, and we have also a work package for all the omics biomarkers led by Anna Maria Cataneo in Italy. So we had to decide how we are going to define response after 24 months of follow-up, and we decided to rely on international agreed definition of sustained remission, defined by 8 consecutive weeks with a QID score below 7 and a manic score using the BMRS scale below 7. And if the patient never completed this sustained remission criteria over the 24 months, was defined as a non-responder. If the patients fulfill this sustained remission criteria at least one time during the follow-up, we then look if this was obtained with the initiation of another mood stabilizer with lithium, and if that was the case, the patient was classified as a partial responder. If this sustained remission was not obtained with the initiation of another mood stabilizer, then we looked whether the patients presented any relapse. If yes, then he fell into the partial responder category. If no, that was the definition of a good responder. So as you can see, these are quite strict criteria. These are examples of what looks the 24 months of follow-up looks like. When these numbers here represent the QID score and the BMRS score during a week of follow-up. When the color is blue, it corresponds to the sustained remission criteria, QIDs below 6 and BMRS below 7. And so we have a color representation of whether the patient is euthymic or not. Here you have an example of a good responder patient, and here you have a representation of a non-responder, a patient who took lithium for 2 years but never fulfilled the sustained remission criteria. Then you have more complex pictures. This patient did fulfill the sustained remission criteria, but afterwards relapse, and this is a good example of a partial responder. And here you have an initial non-response, and then the patient remain well for the last months of the follow-up. You could see this patient as a good responder, but what happened is that on month 12, another mood stabilizer was initiated, and so despite the perfect stabilization here, this patient is classified as a partial responder. So here are the numbers where we end up. So the mean duration of follow-up is 6 months, and we had a quite significant numbers of dropout that are described in this slide, and starting with 169 patients, we only had 62 that completed the 24 months. I am going to describe this further. These are the numbers, how the patients are classified into good responders, partial responders, non-responders, and unclassified. And we use 3 definitions to classify the patients, three different criteria to classify the patients. We first classified them on their status at end of follow-up to include also the patients that did not completed the 24 months of follow-up. And you see here the numbers. We also use intent to treat criteria, and patients who completed more than 12 months were also classified, and we also more strict criteria, per protocol criteria for patients who both completed the 24 months of follow-up and were adherent, for which we have argument for good adherence to lithium. As you can see, we end up with a quite low number of non-responders, and in this, using this classification, and this is due to the fact that within the quite significant number of patients who drop out, we observed that many of them were non-responders, and that was the reason for them to drop out to the study. I am going to present the available data for analysis. These are the numbers at M0 and M3 for all the neuroimaging data. These are the numbers we have at M0 and M3 for the biological studies. And these are the numbers for the clinical data with the ESRF and the actigraphy. As you can see, not many patients completed the actigraphy and the smartphone optional modules. So I would like, for the second part of my talk, present one example on how we handle data analysis to identify a molecular signature of lithium response. And these example I would like to share with you is based on the work we done to identify an epigenetic signature of lithium response in peripheral blood. The first study we performed compared the metylomic marks in 11 non-responders compared to 15 excellent responders. And to do this analysis, we applied a methyl capture sequencing technique. We then applied some filters, and we end up with a signature of 7 differentially methylated regions that discriminate non-responders to excellent responders. And you can see that the area, the rock plot and the area under the curve was quite encouraging with a sensitivity and a quite good sensitivity and specificity combination using these 7 differentially methylated regions. The next step was to perform a replication study on the same sample using a different technique, methylation sensitive high resolution approach. And we were quite happy that 3 of the 7 differentially methylated regions were replicated in using this, this technique, and again with a quite interesting specificity, sensitivity, and area under the curve. We then wanted to move to a validation study in an extended sample of 70 patients. And here we were a bit disappointed because the initially identified DMR, differentially methylated region, did not provide such a good specificity, sensitivity, and area under the curve, even if we considered that there was some interesting signal in this extended sample. We then decided to include in the combination of variables to discriminate good responders and non-responders, to include clinical characteristics that are associated with lithium response in the literature: age, gender, age at onset, family history of bipolar disorder, comorbidities, psychotic first episode, and number of hospitalization. And so we decided to combine, to try to identify a model combining clinical variables and metylomic marks. And we were quite happy to show that the combination of the clinical variables with the DMR, allow us to end up with an area under the curve interesting. So the perspective are the following. So the question that came out of this preliminary work were whether these epigenetic signature that discriminate good responders to non-responders are specific of bipolar 1 because we only included bipolar 1 patients. Is this specific to lithium? Can we, because we haven't tested these differentially methylated regions in valproate responders versus valproate non-responders? Of course, all these data I just presented have been obtained in patients with a retrospective assessment of lithium response, and we are very motivated to confirm this in the prospectively evaluated patients in AirLinks. So that's the analysis of these differentially methylated regions in the prospective sample of AirLink is one of our priority. And of course, we already know that we will need some replication sample because the prospective samples are the gold standard to validate biomarkers to predict response. And so we are actually preparing the application for next calls. So I would like to thank all the consortium members. As you understand, this AirLink study represents a huge amount of efforts for data collection, but also for the analysis of all these biomarkers. So I would like to thank all the partners, and I would like also to thank you for your attention. And